So in the interest of time, we will start this session. The session will be a little bit shortened due to the fact that the first speaker, Professor Chen, was not able to reach us. So with me as chair, I have Mila Kovacevic on the right and Tanveer, our friends, as chair with us. And then we have as panelists, we have Eun-Seok Shin, Carlo Briguori, Jean-Louis Gutiérrez-Chico, Dobrin Vassilev, and Kristian Wachtell. So during this session, we have the possibility to hear and discuss a little bit more extensively the results of important trials that accumulated during the last 12 months. And so the first speaker will be Niels Holm. Okay, so Niels, come to the podium. I mean, he had other talk, you know, all of you know him, unintended deformation of stents during bifurcation PCI, and October important trial substudy.
Thank you very much, and thanks for the kind invitation to speak about this interesting topic. These are my disclosures. So when we do bifurcation PCI, we frequently intentionally deform our stents, but this talk is about when we do it unintentionally. There are several mechanisms, but two main mechanisms. One is the accidental abluminal rewiring, as in this case, where the wires are outside in a malapose stent. If you inflate a balloon now, you will crush the stent. The other main mechanism is guide catheter collision. You can see it here on the angiogram to the left. The guiding catheter is pushed forward and the stent is longitudinally compressed. And by OCT, it frequently looks, as you see to the right, where you have still a circular stent at the lumen wall, but also a pile of struts, several layers of struts suddenly found, typically in the more proximal part of the stent. Bifurcation PCI, in particular left main bifurcation PCI, is particularly susceptible to guide catheter collision. As long as you still have a jailed wire and also a luminal wire, the guiding catheter will be attached to the stent edge. So every time you manipulate the guide catheter, you apply that force to a very small point on the stent edge. We also seen collisions with child catheters. This is a case we published a few years ago where a child catheter catched onto the stent in the middle of the stent, and we realized that it looked okay and didn't do any further, but 3 months later the patients were back in the cath lab and the stent was collapsed. So this small damage to the stent completely destroyed the radial properties of the stent in that area. We also see a combination of mechanisms here, longitudinal stent compression, and you could see the wires are outside the stent and the stent has been crushed. So here you also just have a pile of struts at the end of the procedure, and you need to clean that up. They are even pooled in the ostium of the circ here just to increase the onset for this patient. So there are multiple cases showing that this is a real problem, but there are very few registries pointing to this. I just want to highlight this particular registry from 10 years ago, already then showing that by IVUS assessment, 8% of left main cases had stent deformation as detected by IVUS. And in the core lab, it was only able to detect this by angiography in 18% of the cases, meaning that this is something you need intravascular imaging for. We have not seen these results published, but the Excel trial reported here at EBC 2017 by Gary Mintz that 6.6% of the left main stents were crushed in the ostium, and that was related to increased 2-year MAs in the trial. So we had good reasons to try to avoid unintended stent deformation in the October trial, so that was a focus point among all the other regular focus points with stent expansion and good lesion coverage and all that. We got a primary endpoint that was positive, a 30% risk reduction, And we also had a design that allowed for some mechanistic insight here later on, that we mandated performing OCT after each rewiring. So we found that the two main mechanisms, as implied in the beginning, was abluminal rewiring and guide catheter collision, was 44 and 40% of the cases. And we had 2 cases with fractured wire, when removing that wire caused a substantial distortion of the stent. And then we had some uncertain mechanisms, but most likely they were due to moving balloons and catheters back and forth inside stents. The biggest problem was in the left main setting, where 18% of the cases had unintended stent deformation at some point during the procedure. Looking for abluminal rewiring, we were a bit surprised to see that more than 5% of all cases had accidental abluminal rewiring. It was identified in a little more than half of the cases, but unfortunately left unidentified in 45% of cases, and then led to accidental crush of the stent. If we saw the relation to the clinical outcomes, we found that if unintended stent deformation were left untreated, well, that was clearly related to increased MACE. And in the cases where it was treated, so we corrected unintended stent deformation, we had no cases with MACE in that group. So now we have the 1A indications in the guidelines, and the left main stem and true bifurcations are highlighted, and we show with this trial and also many of the other trials that support the 1A indication that imaging guidance do improve clinical outcome. But I think we also showed with the October trial that there's still a lot of room for improvement, meaning we have not seen the full potential of intravascular imaging yet, when we only discover half of the problems in these cases here. If you wish to see how we did it in the October trial, this is the October guiding protocol. It can be downloaded on the American Heart Journal page or via this QR code here. So in conclusion, unintended stent deformation was seen in 9% of cases in the October trial. Accidental abluminal rewiring and guide catheter collision were the two main mechanisms. Accidental abluminal rewiring occurs in little more than 5% of cases in contemporary bifurcation PCI. Unintended stent deformation was associated with higher MACE. If we corrected it, it offset the increased risk of MACE. Training may increase the clinical value of imaging guidance looking forward to into the future with more use of intravascular imaging. Thank you very much.
So we have now time for questions. First one.
So,
okay, in the meantime.
So Niels, I mean, obviously people should be trained to pull back the guide before they move things around in the left main. So first of all, do you see deaths associated with this deformation in your MACE category? Secondly, in the OCT pullback, did you notice the guide just moving forward with the mechanized motion of the device?
For the latter question, no, because of course sometimes you need to push to hold the guiding catheter, but more frequently you will see that it actually pushes back out of, because you flush and it moves backwards. The OCT catheter moves inside a sheet and should not draw the catheter inside. To the first question, yes, the only procedural death we had in the OCT arm was a severe stent deformation in a left main case, a two-stent technique where certainly steps were not done in a correct way, and suddenly it was a crushed stent in the left main, and the patient thrombosed and died during that procedure. And then there was all other cases that died during follow-up, yes.
How often did you use stent implantation to correct your problem?
I don't have those numbers. So it was dealt with in two ways. Some were just post-dilated again, but when it was quite excessive, another stent was implanted in most of those cases. So yeah, but I don't have the numbers for you here.
I have
Thank you.
one question. Any impact of a stenting technique in two-stent approach, I mean, in the rate of abdominal recrossing?
So the most clear relation was the precision. So the more proximal in the left main, the worse the problem. So it was not really related to if it was a two-stent technique or a single-stent technique. So it was seen with all techniques. We couldn't see that it was much different. But the longer the procedure, the more you had to do, the higher the risk that we had this problem.
And you also mentioned that in 50% of cases, it was unnoticed that there was abdominal rewiring. And in this trial, there was experienced operator performing PCI. So we should search for this abdominal rewiring. So it's in 50% of cases to remain unnoticed is also like high percentage for such a trial, controlled trial.
Yes, so I think that's a very important finding because it highlights what we have discussed previously in this meeting, that training is extremely important. We should also notice that we had absolutely expert operators in the trial, but we also had some with limited experience with OCT. So we had a broader mix than has been communicated in some meetings. So we did have some that were on the learning curve. But even for experienced operators, this can be difficult sometimes to identify, and it requires that you systematically follow the wire out of the stent. With more training, it would be, all the operators, they received 2 to 3 hours of training on the initiation meeting, and it's trial running quite long. That's very, very little. Of course, they got also the procedural feedback. But this is a technology that requires training to have the full potential of intravascular imaging.
We had also a series of stent distortion that we reported 10 years ago. Was not published because it was based, the distortion was based on stent enhancement, which was not accepted at that time as guidance. So just a few words to. I know that in the room you know how to avoid that, but I think it has to be repeated. When you do a crossover stenting, immediately after the deployment of the stent in the main distal vessel, you come with a bigger balloon and you do the pot. This is the things you have to do before doing anything else. Another important thing that we discovered at that time, you need supportive wire. Because if you use less supporting wire, and if you practice the exchange of wires, that your guiding will go out. And these 2 supportive wires help to keep the catheter away from the stent, inside the aorta, really, 1 or 2 centimeters. And of course, to make the exchange, Marie-Claude Maurice said us that we had to bring a 3rd wire. You go with a small loop to cross the proximal part of the stent toward the LED. Then you pull with the shape, you enter the most distal cell. After that, with this also supportive wire, having the guiding inside the aorta, you will be able to free the gel wire. I think these things are simple, and I remember that after application of this, from 8% was even more than in Excel. 8% we found incidentally 1 or 2 a year.
But they were doing pot, right? They were doing pot by protocol.
Yeah, but all these
And
small
still?
details. Don't leave a guiding catheter close to the stent, because at least when you have the gel wire, after that you can manage to have the guiding inside the deploy stent. But with the gel wire, you push. It's typical. This is asymmetrical stent deformation. The proximal part of the stent has this shape. We recognize very well. And we see that very well also with stent enhancement.
Okay.
Thank you. Thank you very much. Next speaker, I think it's Gilles Montalescot, but the presentation is recorded, as I understood, yes. The title is Ticagrelor versus clopidogrel for complex PCI in chronic coronary syndrome.
Good morning. I am Gilles Montalescot. I'm professor of cardiology at PT Hospital, and thank you very much for this invitation to EBC. And the title of my presentation for today is Ticagrelor versus clopidogrel for complex PCI in chronic coronary syndromes. And clearly, we will be discussing this topic according to the Alpheus trial, which was published in The Lancet. And we had a subset analysis in complex PCI cases. So first point I would like to make is that clearly we have an impact of myocardial injury and periprocedural MI on clinical outcome. There is a solid literature about it. It has an impact on long-term mortality and on cardiovascular events in general, as shown here in 2 studies. But we have a lot of studies showing exactly the same thing. So the study design is pretty simple. We recruited patients who were very stable for the coronary disease and were scheduled for PCI, and they were randomized for Ticagrelor versus clopidogrel. They had a negative troponin at baseline, and they were followed up in the next few hours until hospital discharge for the troponin rise after stenting. And clearly, we continued Ticagrelor and clopidogrel for the next 30 days, and we have a follow-up at 30 days for these patients. The study was conducted in 2 countries and in almost 50 centers. The inclusion criteria were pretty simple. Elective PCI with at least 1 high-risk feature, and you have a list of these high-risk features. They were either patient-related or procedure-related. So it was a procedure with a certain degree of risk for the patient, clearly. We had an informed consent signed by all the patients, of course, and we did not enroll patients on oral anticoagulation, and of course, nobody was with an ongoing ACS at the time of this PCI. We had a small platelet function study showing that indeed Ticagrelor was more rapidly active and more potent than clopidogrel, as shown here, in terms of the VAS platelet reactivity. So this is something that we know, and this was confirmed in this study when we compared in a randomized fashion Ticagrelor to clopidogrel. The primary outcome, again, periprocedural MI or myocardial injury, was not different between clopidogrel and Ticagrelor. And we had no difference for MI, no difference for stent thrombosis, no difference for myocardial injury. This was clearly a neutral effect of Ticagrelor versus clopidogrel. When we look at the Kaplan-Meier curves up to 30 days, of course, we get all the events early on, and it's pretty stable afterwards up to 30 days. Clearly very few events in this study. I mean hard events, death, stroke in particular, and clearly PCI was a safe procedure for this group of patients, but we had quite a number of periprocedural MI. The safety was good. At 48 hours, we had no difference in bleedings, no difference for major bleedings, but no difference for nuisance bleedings or minor bleedings between the 2 groups. But at 30 days, we had an excess of minor bleedings, which was significant in the group receiving Ticagrelor. And that was expected, but it was confirmed here, more minor bleedings with Ticagrelor than with clopidogrel. Again, dyspnea was more frequent with Ticagrelor. Very interesting here, we published at the same time a meta-analysis of Alpheus with Ticagrelor and Sassicaia, which is a similar study performed with prasugrel by Shin, and this study was much smaller and was stopped prematurely, but the data were available. And when we pulled all this data together with Ticagrelor or prasugrel, the data were very consistent, and clearly there was no advantage whatsoever of these potent P2Y12 inhibitors compared to clopidogrel for elective PCI performed in stable coronary patients with a chronic coronary syndrome. So what we did also is to look at complex PCI in this group of patients on the basis of the procedure and on the basis of the angio. And as you know, this is quite well defined in the literature. So we took all these items to define the complexity of PCI, in addition to the highest features that we had to select the patients for Alpheus. So we have now complex PCI in high-risk patients undergoing scheduled PCI. And the primary objective and secondary objectives use exactly the same endpoints for these analyzers. And what you can see here is that we had roughly 50% of this population with complex PCI and 50% of patients with, let's say, non-complex PCI in Alpheus. But some patients had several criteria for complex PCI. 15% of patients had at least two criteria, and 10% of patients had 3 criteria. And we looked also at the subsets of patients to evaluate the same comparison for the highest risk patients in terms of complexity of PCI. So this is what we found for the primary endpoint. Again, periprocedural MI and myocardial injury. Of course, with complex PCI, and that was expected, we have more events than with non-complex PCI, roughly 45% of events with complex PCI and 25% with non-complex PCI. But importantly, there was absolutely no significant interaction between PCI complexity and antiplatelet therapy, the randomized groups, for the primary endpoint. So clearly, again, even for these complex cases, there was no advantage of Ticagrelor over clopidogrel. We looked at a couple of secondary endpoints, and according to the number of complexity features that we had for this population, we defined 3 groups: low PCI complexity, only 1 item; intermediate, 2; and high PCI complexity with 3 or more of these factors. And again, whatever the level of PCI complexity, we couldn't find a benefit of Ticagrelor over clopidogrel to prevent this troponin release after PCI. So clearly, this is an important finding. I think the job is done by aspirin and clopidogrel, and we do not protect the patients better with aspirin and Ticagrelor in this kind of elective PCI. Interestingly, we had recently the guidelines for these chronic coronary syndrome patients, and for PCI, they said that actually Ticagrelor or prasugrel could be used with a 2B recommendation in complex cases with a C level of recommendation. This is very funny because we have 2 randomized studies, one published in Circulation, the other one published in The Lancet, absolutely not mentioned, and they conclude to the opposite of what we found in these 2 randomized studies. So in conclusion, from Alpheus, especially for these complex PCI cases, we have indeed higher rates of periprocedural and MI and ischemic events when these elective cases undergo complex PCI. There is a stepwise increase in the risk of periprocedural complications in case of combination of several criteria for PCI complexity, but there is no significant reduction of periprocedural MI and complications by Ticagrelor in comparison to clopidogrel across different types and degrees of complexity. In stable coronary patients, outcomes may be related more to the complexity of the procedure itself than to the potency of platelet inhibition. And I think our studies and subset analysis, as well as the Sasikaya study, both go in the same direction to say the gold standard treatment for elective PCI whatever the degree of complexity, is aspirin and clopidogrel. Thank you very much for your attention.
Is he connected? No. Okay. So it seems that Gilles was not able to connect timely. So anyway, I think that it is very, very interesting study to be commented, because we see that in the same period we have a study that is a confirmation for a previous study against, and the guidelines that give recommendation.
Yeah, but the endpoint was at 30 days, 48 hours after, like for primary endpoint. But we cannot estimate that giving the Ticagrelor to the patient with chronic coronary syndrome will prevent MI during the procedure. It's technical related issue, like whether the patient is going within 48 hours. Usually when there is stent thrombosis, I think this is my fault, like as intervention cardiologist, not the fault of the medication therapy. Usually this is my opinion. So maybe this primary endpoint, like 48 hours after giving this treatment, maybe can be discussed, like in the matter of like MI. But okay, regarding the MACE at 30 days, then we can talk about whether to switch the patient to do escalation from clopidogrel to Ticagrelor if we have complex PCI patients, like if we have 2 stents in left main, whether to do guided escalation, like to perform multiplate test, and if the patient is non-responder for clopidogrel, to give the patient Ticagrelor, for example. I don't know what is your opinion, but in regard of this, yeah.
So it's not uncommon to have an 80-year-old with calcified distal left main, 2-stent strategy. So it goes beyond that. And the other thing is they talk about 3 to 6 months. I'm very uncomfortable just saying 3 to 6 months of DAPT, rather give them a year of DAPT. I mean, and should these people be tested genetically or not? We don't have any clear-cut answers for that.
Yeah. Any other comment? So also, so it is true what you said, Mila, but anyway, the data also shows what you are saying, that the complexity by itself is strongly associated with increase of events. So once more, I mean, we are here to refine the techniques, since there is really a clinical need that is apparent across different trials, even in trials that are not designed on the technique. It happens that it is true that technical aspects may influence the outcome of the patients. And for me, this trial and the comments by Gilles document the fact that we have no parachute that can prevent us from having dreadful complications in the case we do not fix everything in the best way.
And do you think this might change a little bit with Ticagrelor? Because now in some patients with debatable indication for potent antiplatelet, now we have the chance probably to bridge these initial phases in case of complex PCI or acute coronary syndrome for 4 hours with Ticagrelor. And I mean, we have positive experience in this regard.
So I mean, my perspective is the fact that the signal is not in favor. So we will see, but also the fact that in these trials they use drugs that have been associated with clearly laboratory assessment increased in platelet anti-aggregation that does not translate in benefit, seems not to, I mean, be a potent signal for other parachutes.
I think coming back to the complexity of the PCI, it's most likely because the complexity of the PCI is a proxy for older patients, higher bleeding risks, turn down of surgery, all of the above, and that kind of drives obviously higher risk for events in those patients that have lower risk. Correct.
Okay, so we go on.
So it's a pleasure to introduce Dr. Yang Su Zhang, who will talk about the OCCUPY study, which is the optical coherence tomography guided coronary intervention, PTS, with complex lesions, randomized trial. Dr. Jang.
Do you have a recording or not?
We don't have any from
Is Dr. Jang not here?
And you have no recording?
no record and
Okay. So we'll move on to Dr. Gori talking about randomized non-inferiority trial comparing reverseTAP versus DK, crush stenting for the treatment of complex left main bifurcation lesions. Dr. Gori? Thank you.
I'm here. So well, I have more time for discussion, right? Half an hour. So first of all, thank you very much for the invitation to be here. It's an honor, and especially for being invited to talk into a big trials session, whereby I honestly believe that my study is actually a product of laziness in the cath lab rather than a big trial. So this is the title that I kept because this is the title of the paper that is published. I actually, the study is a comparison between DK crush, now become traditional. At that time, was not so traditional technique for the treatment of complex bifurcation lesions, and a simplified version that I then called reverseTAP, and that is actually some form of protrusion and flare technique, and then we can discuss about the nomenclature and the semantics. Now, of course, this is something that you're familiar with, the MADS technique, and what I want to discuss here or present here or state here is that all the lesions treated in this little trial were very complex. So they had at least two of the paradigms of complexity as defined in the DK crush trials, very calcific lesions, some with thrombus, and definitely left main lesions. So at the time where I came up with the idea of doing something a little bit more simple for the treatment of complex bifurcation lesions, the 5 DK crush trials had been just published. So it is a while ago. And as I said, this study is a product of laziness in that I found at that time that the DK crush technique was a little bit complicated, hard to reproduce or spread into every single center that is equipped with interventional cardiology, and that this complexity could result into some troubles that Dr. Holm summarized under the rubric of deformation of the stents. So you will need 2 rewiring procedures. You will need a crush causing struts to be potentially floating into the lumen. And then you will need a kissing as compared to alternate PTCA of the 2 branches, thus limiting the possibility of expanding properly the 2 ostia of the vessels. So I came up with this idea of applying the concept of TM protrusion in a reverse way, and from that the name of the technique that I used at the beginning. And this is the technique that I compared in this randomized trial with the traditional DK crush. So the technique will be also a little bit complex, but involving only 1 rewire. Would involve placing first a stent with a very minor protrusion into the main branch. The first stent will be placed into the side branch. Then this stent will not be crushed by the sentinel balloon in the main branch, but rather alternate dilation will result into a flaring of the stent along the circumference of the side branch ostium. The following steps will be, and therefore this technique will not involve a first rewiring and crushing and kissing. The next steps will be very similar to the DK crush technique, therefore implantation of a main branch stent, pot rewiring of the side branch for the only rewiring necessary in this technique, and then kissing and repot, and then final result. So this was an animation which I skipped. So this slide summarizes a little bit the differences between DK crush and what I call then reverseTAP, and we can discuss again about the semantics. DK crush would require at least a 2 millimeters protrusion, sometimes a little bit more depending on the angle of the bifurcation. reverseTAP will require no protrusion or very, very minimal protrusion. It will require only one rewiring and then very, very aggressive alternate inflations of the main branch and side branch balloons in order to obtain dilatation of both the ostia. It would require no crushing, as I said, but flaring across the circumferential extent of the side branch ostium. And of course, as I said multiple times, just one rewiring as compared to two rewiring. So in order to compare formally the two techniques, I tried to run a randomized controlled trial comparing the decay crush with this reverse tap technique. I hypothesized that a non-inferiority trial would be the appropriate design because the idea was that the reverse tap technique is an easier one, and therefore the advantage and therefore the need of a non-inferiority trial in terms of endpoint as compared to a superiority trial. The primary endpoint, of course, in a randomized controlled trial, you have to choose one primary endpoint, and the most reasonable to me seemed to be the stent expansion at the level of the side branch ostium, which is also the position where we learned in the previous session most of the restenosis occur. So the study was, as I said, designed as a randomized controlled trial. It's one center. All lesions were Medina 011 or 111. The power was calculated, next slide, for 50 patients, randomized 1 to one or the other. And of course, the endpoint was measured immediately after procedure with OCT. There was, of course, a safety endpoint at 6 months. This is the power calculation. Power calculation was based on the DK Crush 1 trial. Essentially, said very shortly, I assumed that the reverseTAP method would result in at least 50% of the advantage of DK Crush as compared to traditional crush, as shown in DK Crush 1. This is the study flow, 208 lesions that could have been treated with this technique during the recruitment period, landed with 50 patients, 25 per group for one or the other reason. This is a very busy slide presenting all the differences between the two groups. Essentially, there were no differences. It was a randomized design, except for two, which are very important. One is down, I can see it better if I see it here. Down here, we actually used more pressure during the final kissing balloon in the DK Crush group. That should turn into an advantage for the DK Crush technique. And the other difference, which was hypothesized to be so, is that the reverseTAP technique was much faster than the DK Crush technique because it also involved only one rewiring as compared to two rewiring. In terms of procedural outcomes, safety outcomes, there was no difference. As we learned from the previous presentation, there was quite a few patients with troponin elevation. It was 13, so about 50% in each group, which is what Dr. Montalescot also showed, but no difference between the two groups. And this is the primary endpoint of the trial. The study was again powered for non-inferiority, which was met. And on post-hoc analysis, the reverseTAP method showed actually superiority in terms of side branch stent expansion as compared to DK Crush. Other than that, there was a very similar main branch opening data, and there was a similar malapposition in both groups. So this shows the 6 months OCT follow-up results summarized on the left side. There was less neointima proliferation in the reverseTAP group, a larger opening area at the ostium of the side branch, and more malapose struts in the reverseTAP as compared to the DK Crush, without clinical implication, at least in the first year of follow-up. So in conclusion, protrusion and flare, this is the changed name of the procedure, of the technique strategy for the interventional treatment of complex left main bifurcation was non-inferior and actually superior to DK crush. For the primary endpoint of the study, which was side branch expansion, it actually required less time, which is an advantage. It was also less complicated because it only required one rewiring, and at 6 months it had very similar results. Thank you very much.
Any questions?
You have half an hour for questions.
Thank you very much for the nice data. My question is about Mila position. In which side of the bifurcation, which level of the bifurcation was the Mila position observed in the reverseTAP technique, and how do you explain that?
Yeah, I have no explanation because we only saw it at 6 months and not before, and it was at the carina. Yeah.
So was the carina covered in your initial index procedure by imaging? You did OCT in both branches, right?
Yeah.
And the carina was covered.
It was opposed. Yeah.
Opposed. So there's no gaps left, basically.
There were no gaps left. It's probably some form of positive remodeling potentially of the vessel. This is the data, but as I said, I have no real explanation.
I have just a question. We have learned from October trial that the unintended stent deformation by OCT occur at least 5% of complex bifurcation. Any case in your study?
Yeah, if I had known that there was this endpoint, I would have used it in the study. Actually, I found it a very instructive presentation. Yes, there were stent deformations, and I would say that they were more frequent in the DK crush group, but I cannot substantiate this statement. I'd rather not say anything about it.
Yes, and may I just, so it was an excellent presentation. My question is probably in the comment that the strategy is going to be determined according to the bifurcation angle, because this is the main point. If the angle is wider, then reverseTAP is much more convenient, and vice versa. So if there is a narrow bifurcation angle, then the protrusion is going to be larger. Then probably there can be a crushed by the main stent, main vessel stent implantation, probably. According to regarding to the side branch expansion, what we have learned also to do in DK crush technique, to do flaring also of the stent in side branch before we crush it. Then the expansion of this stent is going to be larger in comparison. Whether, if we don't do flaring, for example, I wanted to say it like, so the flaring is also involved in DK crush technique as well, like optimization of the side branch ostium.
Yeah, so absolutely agree with both comments. In terms of flaring, yes, it is very important. It wasn't in the guidelines to DK crush at that time, so therefore it wasn't done at that time, but absolutely, I totally agree with you that it's very important and it should be done. Now, in terms of the angle of the carina and the angle of the bifurcation, I can only say that I'm not a Taliban of this reverseTAP procedure, and I do DK crush, and I totally agree with you. If the angle is narrow, then DK crush is definitely my choice. Yes.
Yes. Question there.
I really enjoyed that presentation. My first EBC 2006, I think, in Valencia, we multi-site study did something very similar from Australia. We called it shunt, and we modified T-stent. I moved away from it because it's a pseudoscience, and we try and mould that stent, but sometimes we would sort of undershunt. So the stent is a bit too far back, more than 2 to 3 millimeters. So DK crush was developed to allow and permit very high rates of final kissing. So if you do enough of these, or our shunt, your reverse flare, you do get a heterogeneous result and it can make it very hard to do the final kiss without doing the first kissing with DK crush. So it's just a comment, not a criticism. Yeah.
Yeah. No, I do agree with you. A fair comment. Yes.
Yes, I have a question. And I'm more favor the reverse tap technique because that is relatively simple to the decay crush. However, we need long-term clinical outcome data. So do you have any plan to?
We will follow up on those patients, yes. Okay. The problem is that it's a small study. It's definitely not powered for outcome data. The follow-up data or the clinical follow-up of the patient was only meant in terms of safety. Of course, if we would have had a signal towards stent thrombosis or restenosis, that would have been important to report. Yeah.
Tommaso, we will have a short discussion about the discussion we have not done last year. So, from the beginning of EBC, and after that, Francesco, we are taking care to build the names by families, to avoid to have the same procedure with several names or the contrary. So, TAP is a provisional strategy.
Yeah.
That's a question. We were fighting with Antonio Colombo a long time ago about inverted or reverse. So we choose for a provisional, when you stand towards the side branch, we choose the inverted. So the reverse is available. So I accept reverse, and for TAP, I think we can find maybe something better.
Yeah, as I said, I've published it, and I can't change it now. It would be.
But
we can send a correction. I'm very open.
Maybe we'll exchange during the next week. All the assembly here.
No
propose
problem.
Something.
Let's make a poll.
This is very close to the modified stenting. That was what was the name of the Japanese with Antonio Colombo? Kobayashi. Yeah, Kobayashi. Was modified stenting. Was just before the crush. It looks like the only difference is the dilation. So you have to introduce that in modified stenting.
We have another question.
Yes,
Dr. Gori, half an hour.
Yes, I still have some time here left over. Okay, congratulations for the nice idea and the going on with this study. I have a couple of questions. Did you investigate the angle, that's the bifurcation angle? Did it have an influence on the carina and the apposition? That's one of the questions, but maybe there's more patients and more procedures are needed to do so. And did you investigate the contrast media, the difference between decay crush and the contrast used versus the reverse tap? But Professor Louva is absolutely right. Maybe it should be called inverted tap or something, but that's a very good idea.
Taken.
But it's very interesting. And one other thing that also the X-ray, was it different? So these are some procedural aspects of this procedure. And one other thing is that maybe should be at least maybe brought into the light, that maybe we should at least have also investigate this procedure against maybe decay culotte, because I think if you have OCT, the primary procedure, but I have a feeling that with the TAP, with the TAP, maybe is it fully covered, the side branch osteum, not the carina side, but the other side? I mean, I have a feeling that there might be some uncovered places regarding the bifurcation.
Yeah. So the two questions that are easy to answer are contrast medium and X-ray time. Yes, they're collected. They're presented in the busy table there. There is a trend towards less contrast and less X-ray in the, no offense taken, reverse tap. Or no offense meant, reverse tap, but it was not significant before I didn't report it, and it was not to be reported. The other question was the angle. I didn't find an impact, or actually I had not enough power to show an impact of different angles on different outcomes, because the study is so small, 25 patients per group, so I couldn't say it. The final angle after the implantation was tended to be higher in the reverse tap group, so more towards 90 degrees. The inclusion was, I mean, one of the inclusions, of course, even just subconscious inclusion criteria is that all lesions could be treated with both techniques, of course. Yeah. So, and in terms of comparing this technique with double kissing and culotte, of course, if somebody wants to do it, I'm very happy to participate.
Flared distanting. Flared distanting.
Flared distanting.
He loves names. So one more question. How are you sure 100% that your technique is different as compared to nano crash?
Yeah, that's
nano crash. I mean,
yeah.
It is reported. I mean, we had many reports, because at the end, I don't think that there is any possibility to be sure that there is some kind of crash.
Yeah, so at the time where I submitted to ethics, let's put it as a beginning time, but of course I had treated patients already outside of the study. There was no nano crash. It wasn't mentioned yet, so I was somewhat free to call it whatever I want. It is very similar. I totally agree. Yeah. If you see the paper, in the supplement, there is a comparison of this technique with other techniques, and the nano crash is very, very similar. Yes. What I don't like too much about nano crash is that if you see this technique, there is no crash, there is a flare.
No, but I mean,
So
what a nano crash operator says is the fact that they are able not to crash due to the fact that they protrude not enough to reach with the 3 layers.
The other side.
So and when they perform imaging, they do not find any areas where there are 3 layers. That is the hallmark of, crashing, the fact that you reach.
There is a difference with nano, is flared.
Yeah.
Last comment by Remo, because he was the one who characterized.
Yes, this is a nano crash. The nano crash is there was no name. It's a nano crash. The difference between the nano crash and your technique is that the nano crash uses a balloon inflated, or deflated. There are 2 techniques of nano crash. I use with the balloon inflated if you do a left main, I inflate the balloon in the left main LED. This allows not to stabilize everything, because the stent, the ostrom of the circ is dancing because there is the motion. But when you inflate the balloon in the left main LED, then you pull your stent in the circ, you can position precisely. In addition, if you size this balloon to the LED, to the distal main vessel, you can still inject and see, because there is some flow below the left main, because the balloon is sized to the distal main vessel. And this way, you have just a neocarina, which is 1 or 2 millimeter, which is crashed. And you crash directly doing the kissing immediately. So the crashing is doing with the kissing immediately. And in addition, you can explain why you have more side branch size. Because when you re-enter in the side branch, you re-enter through the stent through lumen. Through lumen. The stent has a true lumen, which is...
Do not get too enthusiastic.
Yeah, no, but this is the secret. The true lumen is that lumen of the stent, the nominal lumen that you can expand the stent. So if I put a 3O stent in the circ, the 3O stent, depends on the brand, can be expanded to 5 millimeter, But if I do a crash, I do not re-enter in the true lumen. I re-enter to the side branch. Is an opening. And this opening can never reach 5 millimeter. So there is a limitation, because with the crash, you re-enter in the side of the stent, not in the... And this is the reason why you have more a position and better result using the nano crash compared with the decay crash.
Yeah, actually, I understand. I agree with it. I think that that one very, very important point, as you said as well, is the alternate dilatation with high pressure, which was not in the decay crash procedure at that time. Yeah.
Patrick is right. We are completely crazy. You said that we are people crazy to spend a whole weekend on the bifurcation stenting. You're right, completely crazy.
Okay, we go on. Okay. So last
So the last speaker for this session is Antoinette Nelon, only a part, the KISS trial. Is this in person or is this recording? Recording.
Dear Chairman, thank you for the opportunity to present at the EBC 2024 meeting. My name is Antoinette Nealon, and the title of my presentation is Only a Pot, the KISS trial. We must remember that it's only very recently that we've had some hard clinical data on the importance of performing a proximal optimization technique. And this data comes in 2021 when a bifurcation subgroup of the Ultimaster registry of over 4,000 patients showed us that the performing of a pot had a benefit for patients in terms of lowering target lesion failure. And this was very specific to performing a pot, because when they looked at kissing balloons as a substitute for pot, we didn't see this impact in target lesion failure, and there was no interaction effect for the use of both pot and kissing balloons. So it really comes back to the importance of performing the pot. In this other OCT study, we see a smaller number of bifurcations, and here they studied the impact of pot with side branch dilatation versus kissing balloon dilatation on strut apposition and the number of jail struts before the bifurcation branch. And inversely, in this study, we found that kissing balloon technique gave a better OCT appearance in terms of reducing malapposition and jailed struts. And what does the EBC tell us in terms of going one step further? Well, there's a very clear message that systematic proximal optimization technique should be performed, but after that, it's a little less clear, and it's left up very much to the operator without a lot of hard clinical evidence. So it was from this unanswered question that the KISS trial was born. KISS meaning Keep Bifurcation Stenting Simple. So when we think about side branch intervention, why might this benefit a patient? Well, maybe we have better rheology. We have less side branch occlusion, less peri-procedural injury, better relief of anginal symptoms, and less restenosis. But inversely, if we don't perform side branch intervention, we're going to have shorter procedural times and less X-ray exposure, and maybe less risk of side branch dissection, therefore less need for second stenting, and maybe this has an impact in terms of the risk of restenosis later on. So the design of the study was all de novo non-left main bifurcations, except 001 Medina, with a side branch that the operator felt was large enough to accommodate a coronary stent. Main branch stenting was performed using the Resolute Onyx stent with a systematic POT. After this, the operator evaluated the side branch, and in the case of no flow reduction or any signs of ischemia, the patient was then randomized to no side branch intervention or side branch intervention. And this side branch intervention was at the discretion of the operator in terms of kissing balloons or a pot-side pot technique. So the study primary endpoint was the rate of peri-procedural MI, and this is using the ARC2 definition, using a troponin, an isolated troponin that was more than 70 times the upper limit of normal, or more than 35 times the upper limit of normal, with additional criteria for myocardial loss. And based on the power calculation, a sample size of 596 patients was going to be required. Secondary endpoints are technical success, acute gain as measured by QCA, procedural time, and X-ray exposure. And the clinical endpoints measured at 1 and 12 months were target lesion failure and its components, definite probable stent thrombosis, and angina status. So this then left us with an intention to treat analysis of 304 versus 313 patients and very small, low levels of crossover. So what are the main results? So this is a pretty typical profile of patients with mostly male and a mean age of 67, 68 years. Majority of patients presented with a chronic coronary syndrome, and ejection fraction was preserved for both. No significant differences in terms of diabetes, with slightly more MIs in the control rather than the no side branch intervention group. So the majority of cases were performed using radial access. In about 20% of cases, there was a non-target PCI performed before the bifurcation intervention. Most of these were LAD first diagonal bifurcations which were treated with a proximal main diameter of around 3 millimeters, which was the same for both groups, and side branch diameter of about 2 millimeters for both groups. Lesion lengths in the side branch was short for both of these groups at about 4.4, 4.8 millimeters. And we have a very high level of POT at over 99%. Kissing balloons were performed in about 40%, with most cases in the side branch intervention arm having a pot side pot technique performed. And again, we see that there was significantly more side branch stenting performed in the control group, with about 4.5% versus the no side branch intervention. So in terms of the primary endpoint, that is peri-procedural MI, what are the results? There is no difference in either the intention to treat, the per protocol, or as treated population in terms of peri-procedural myocardial injury for either strategy. However, in the no side branch intervention group, we have a reduction in procedure time, we have less contrast media volume, we have less X-ray exposure, and less requirement for a second stent in the side branch. And this shows no interaction with lesion location, Medina class, side branch size, or side branch stenosis, as measured by QCA before the intervention. So, clinical endpoints. Are there any differences in terms of target lesion failure, target lesion MI, or stent thrombosis? Well, no, we don't see that coming through at 30 days or at 1 year. That no side branch intervention performs equally as well in terms of the clinical endpoints of target lesion failure and its components. And if we look at the subgroups of kissing balloons versus pot side pot, we see that, again, there is really no difference in terms of either of these techniques for clinical outcomes in the control group. So what has all of this told us? Well, we can see that provisional stenting in routine non-left main bifurcation using the Resolute Onyx stent is associated with good short-term and mid-term outcomes, with target lesion failure for complex bifurcation lesions at around 5 to 6%. That a no-touch strategy is non-inferior at 30 days to systematic side branch intervention, and this is a safe and effective strategy out to 1 year. And this relates just to non-left main bifurcations, so we don't have any information on whether this can be extrapolated to left main bifurcation stenting. So looking at this study as one of the participating centres, has this changed my practice? And I would say that yes, this has changed my practice. whereas with the results out to 1 year showing no difference in terms of angina status or target lesion failure, that I am less inclined to KISS or perform any side branch intervention. This completely underscores the importance of the pot. And perhaps in the future, it would be interesting to see whether this is something that can also be extended to left main stenting, as while it has changed my practice for non-left main stenting, it certainly has not impacted my practice in any way for left main stenting. Thank you very much.
So, very interesting study, but I think if I have understood correctly, you compare simply POT versus an intervention in the side branch, and 47% of the cases, that intervention was simply side branch dilatation without kissing. I think this is not the standard of care, right? So it's not a fair comparison.
This is POT followed or not?
Yeah.
By KISS.
No. But
No, in the case of side branch, the protocol, I mean, we have been involved in the trial. So in the case there was a randomization to standard of care, the operator was free of selecting either kissing or pot side pot. This was mandatory. So in the side branch intervention, this is the way. So when you see a side branch, there is also followed by repot. So it's incorrect in that. Anyway,
no, it's clear.
40% of cases, yeah.
But
yes,
excuse me, the criteria for randomized, I mean, you do stenting, you did in the main vessel, and then if the side branch was okay, you randomize. But what does it mean, okay? What does it mean, okay?
Mean okay,
no stenosis,
in terms of T-metry flow, and not tight lesion on the basis of angiography.
By visual estimation?
Visual estimation.
Francesco,
but any
POT
data
was mandatory and randomization after POT.
Yes. Okay. Like that, yes, so it was POT. So it was crossover stenting, POT, then if the operator, and this was outside the study, so if there was T-metry flow and no tight stenosis into the side branch, it was no treatment, so procedure finished, or systematic treatment, so systematic treatment in absence of, let's say, guidelines forcing doing, but it is the concept of showing if it is deserved or not to systematically do things.
Yeah, just another question. You decide to randomize at the beginning?
No,
after stenting?
After crossover and POT. Crossover stenting and
POT. So you have a lot of bias.
No, it is not a lot of bias. We should know
very
when.
Selected.
So I think that the correct way of incorporating trials in our practice, probably this is why we are talking here, is to understand which is the flow that generated the data. So this is not a study that is against side branch intervention systematically. It is against side branch intervention in the absence of many things. Honestly, what I was quite surprised to see, side branches that are 2 millimeters. Yeah. This is probably the most important thing, because side branches were 2 millimeters with good flow, POT performed. So in this condition, I think that was promoted in the EBC several times not to do in this condition anything. Now we have a trial supporting it, because in the world there was many people that was probably doing differently.
But just to clarify, the non-side lesion, you could have pinching of the side branch, and that would still NTME3 flow.
As I understood, sorry, Francesco, to answer instead of you. As I understood, the mean side branch, like a lesion, it was 30%. and the length was about 4 millimeters. So it's non-complex, non-complex, non-true bifurcation lesion. So it's a limit selected population. 30% of side branch stenosis, 2 millimeters of the side branch, and the length of the lesion was 4 millimeters. So it's like, as you said, pinch of the side branch, like selected population of the...
I was not okay with my associate Bernard Chevalier, and maybe not with but okay, they did the trial. My problem is the same as yours. 2 millimeters, normally they are not included in bifurcation trials since, after Nordic and a long time ago. But okay, we can say, okay, because if they have selected something with 2.5 non-left main, we will have seen a difference. But unfortunately, this is also done for left main. This is popular in Korea. They do a crossover stenting, they do a pot, and they leave the strut in front of the circumflex. They do that since a long time. And they consider this is safe. Maybe we can have some intervention of the, Shangbuk.
But, and in answering to these provocative questions, please remember us about how you check fenestrated restenosis outcome that is usually taking times, years to come up.
Actually, we don't have a randomized clinical trial, it's just the observation registry data. But as you mentioned, that in Korea, we just a simple crossover. And nowadays, Goran mentioned that part is very important to make a better expansion of main vessel proximal part. That's a very important part to prevent the event. So it was very popular. And then now we do the randomized clinical trial across COVID. Last year, I mentioned that. So we do this study showed that the kissing did not make better clinical outcome. So we focus on the simple crossover and part. Then side branch visual stenosis is more than 50%. In those cases, we randomize just leave alone or kiss. So I'm not sure what the result, but we are ongoing trial.
Yes, and in the case of kiss, do you re-POT after or not, according to the protocol?
Pre-part is mandatory, mandatory, but
so it is left to the operator.
After kissing, the report is optional.
Okay. So I think that we can, thank you. I think that we conclude here the session. There were honestly important missings that we should ascertain how happened. Anyway, I think that we had the possibility to discuss important topics. Altogether, they are the pitfalls. We have mechanical pitfalls that we now know that impact outcome. We discovered that there are no drugs, antiplatelet drugs, that can, let's say, forgive us in the case we do. And at the end, we have a new technique that deserve name and deserve, let's say, discussion about the different people that publish similar things in order to find the agreement. I remember the history of TAP. It was simultaneously practiced in Rome and in Korea. So we, with Dr. Juan, decided to come out with a combined combination. So this is also something that is in the spirit of EBC to find names together. And last thing is the fact that in the case it's minor side branch, for people that was deserving it, there is no need to do anything in the case the patient is okay and there is good flow. Thank you.